Ramadan is going great. So we'll start the assessment. I'll wait for a minute if somebody wants to join. If you want to alert your friends to join today's session, you can text them. I'll wait for a minute and then I'll start. Hi guys, so I'll begin. How was your yesterday's session? I got a lot of text messages. You guys did well. Did you find it easy? Are there any feedbacks? Anybody can answer this. How was the test for you guys? Yes, Dr. Rauf.
Ma'am, I had a problem with the assessment
Okay, and what do you feel was the problem?
that I could not complete the test in time.
Yeah, that is why, I say that you need to have a grip on questions because there will be 40 questions in every block for an hour. And if you cannot complete it, the block will log out automatically and, it will jump to the other question block. That is what is going to happen in your exam. So we're kind of, helping you prepare for your exam. And so you need to work on your speed, your timing, solve more questions so that you can do it in time.
Yes, and I was thinking that maybe I should not do the timed mode in UWorld instead of the tutor mode because I could only do 25 questions in 1 hour.
Yeah, so it's you need to work on your time management skills. That is why I always advise to use UWorld and timed mode. And the reason is because then you'll, if you're doing like 20 questions in 1 hour, then you'll kind of push yourself to do more questions and then more questions. And that is how you'll become familiar with the time management. Otherwise, if you have your exam next month and you're saying that, okay, I have like 20 questions or 30 questions per block, then it's going to be a huge problem for you guys in the exam because you have 7 blocks. Every block comprises of 40 questions. And trust me, guys, the questions that they asked you, they were average. And the question stem is very, very long in the exam. So you need to focus on that.
Yes, ma'am. I'll try to improve.
Okay, sure. So we'll start with the assessment. Does anybody also have any opinion? How was the assessment? Did you like it? Was it difficult? They can kind of talk to me about it. But if not, then I'll start with the questions. Okay, I'll share my screen. Okay, so I see a hand raised. Whose hand? Yes, Dr. Jocelyn.
So I wanted to say that maybe this is more of a technical issue, but some of the images for me were not showing up. They would say like reference image below, but then there was no image. But then some questions I could see the images, which I think was a nice touch. But some of the questions, the images were not displaying at all.
Oh, okay, okay. I think it's a technical issue. Dr. Hamza and Dr. Ahmed will look into it, and they will let you know if the error was from our side or what's the problem. They'll let you know.
Thank you.
Okay. Okay. So now I'm gonna start sharing my screen. We'll come on the assessment. Okay. Okay. So we have the first question. Is it visible to you guys?
Can you
Okay.
zoom if possible, please? Can you zoom again, please?
Is it okay now?
Yes.
Okay.
Yes.
So we have our first question from yesterday's assessment session. There was this woman who had HMB, heavy menstrual bleeding. She had IDA, iron deficiency anemia. She was instructed to continue iron supplementation. And what happened was that she is reassured that iron hemostasis is closely regulated. Which of the following is the cells is most likely responsible for secreting this hormone? Okay, what's happening over here, guys? Yes, you can just unmute and answer because I cannot see the hands raised.
Patient is bleeding.
Yes, and
It's
what's the
hepcidin.
They have
yes?
asked about the hormone which is getting released. A hormone is released and functions is reducing the amount of dietary iron absorption from the intestine. So that is the hepcidin, which basically decrease the absorption of the iron from the intestine. And that is released from the hepatic parenchymal cells, not from the bone marrow macrophages, not from the stem cells, and not from the epithelial cells, and not from the renal tubular cells. So it is the hepcidin which is released from the liver.
Very good. So we know that hepcidin is, kind of taking part in the iron hemostasis, and it is released from the liver. The rest were, it was an easy question according to me. So I think I don't need to explain you the concept, what's happening behind it. It's a very general question. It's also written in Pathoma. If you're unfamiliar with it, then it's also written in Pathoma in the RBC, red blood cell disorders chapter. You can go and have a look from it over there. Okay, so we have the
Dr.
second
Maheen,
question.
quick question. So in
Yeah,
that question, so this is just the normal condition. It's not the diagnosis for the hemochromatosis. It's just a normally what happens when there's increase of the iron, right?
yeah.
So meaning that the liver is responding to the highest storage of the iron level, and that is it. It's not about hemochromatosis when there is a mutation.
No, 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 no. It's not about, why is it about hemochromatosis? Hemochromatosis is the iron buildup. It's not iron deficient.
Okay, got it.
Okay. And plus, hemochromatosis is a genetic disorder. There may be a secondary hemochromatosis. Secondary hemochromatosis occurs in transfusion disorders. For example, if you have a patient with thalassemia and we are giving them blood again and again, so, secondary hemochromatosis occurs in those patients who are having repeated blood transfusions. She's taking oral iron supplements, and oral has got nothing to do with an excessive iron buildup. So,
Okay,
yes.
thank
So
you.
the answer is C, right?
Yeah.
Thank you.
Okay. So we'll go to the second question. It says it's basically a continuation, I think, of the previous question. A sample of whole blood from a patient is being examined in the laboratory. These tests show, so we have WBCs, hemoglobin, hematocrit, platelet count is also okay. PTT, what's happening to the PTT? Is it normal or abnormal?
It's tiny bit up.
Yeah, but it's
Okay.
okay-ish. Rizorectin-induced platelet aggregation is reduced. Okay, which process is impaired? What do you think the answer is, guys?
So
The
the
rise of
AWF, right?
yeah, the von Willebrand factor. And the von Willebrand factor because of the ristocetin test. And once it's decreased, there's no binding of the vomeria factor binds the collagen to the platelet. It's platelet to collagen. So it's going to be A.
Yeah.
Exactly. Why isn't it activation of factor 9?
So factor 9 because PTT is within the normal range. I mean a little tiny bit up, but it's not abnormal. So that's why it's not factor 9. It's the
But in
um
one brand deficiency, we also see PTT raised.
PTT
that would
is
be with
raised here.
factor 8, right? Not with 9.
No, PTT
Mhm.
is
Yeah.
raised here.
Ristocetin cannot catch up the
Factor 9
With
deficiency.
yes, with toxicity-induced platelet aggregation, we can rule out two diseases between the Werner Solier and the von Willebrand. So they are saying that this factor, ristostatin-induced platelet aggregation is reduced here. So that's
Mm-hmm.
why it is a binding between collagen and platelet glycoproteins. It is the von Willebrand disease problem.
Exactly. So it's a von Willebrand deficiency problem. We are going to have bleeding time is increased, PDT is increased. We have a normal PT. Factor 8 also gets deficient along with von Willebrand disease. Okay, guys, what is the treatment of von Willebrand deficiency?
Sin, vasopressin,
Yes.
Smoking.
desmopressin. Yeah.
Desmopressin or vasopressin, that's an ADH analog, and it kind of helps increase 1 milligram factor release from the Weber palate bodies of the endothelial cells. Okay, so that is what you need to remember. Okay.
I have a question.
Yeah, sure.
You were saying, why is it not factor 9? I think factor 9, which is it's only for men, not for women, because it's an X-link.
Does anybody have anything else to say? What else could be the reason?
I was thinking VWF is also like a protective agent for the factor 8 if VWF is not working, so 8 would be affected, not 9.
Mm-hmm.
Are you also asking for other things that can affect 9?
Yes.
Like if there is vitamin K deficiency, because K is for 2, 7, 9, 10, right?
Mm-hmm.
And like if there's deficiency of that, or like in cystic fibrosis or something, those proteins could be affected. Although 7 is the most common affected one, but it can also affect 9, can't it?
Exactly. So the answer was von Willebrand deficiency. How do we know? Because heavy menstrual bleeding is a part of that. Plus, what do we also see? We see that the bleeding time is also increased. That we do not see in factor 8 and factor 9 deficiency. That is hemophilia A and B respectively. So that is their PDT is a little bit increased, and they also threw us the distractor of rhizotectin induced platelet aggregation. That's what's happening in von Willebrand and not the other factors. So sometimes when there are distractors given to you and what you have read in a particular pathology in a particular condition, kind of stick to it. Do not use your mind unnecessary because you're wasting your time on a question. Okay, so just whatever is written in the pathology of a question, you just go and just pick the right answer, and that's it. You did not read rhizorectin thing within hemophilia A and B, right? You read it in von Willebrand deficiency, so just go with it. They're not going to ask you anything extra. Just follow the books. Okay. We're coming to question number 3. It states that there was a researcher who was studying the role of integrin receptors in the primary hemostatic pathway. She has isolated a platelet receptor that binds fibrinogen in response to stimulation by thrombin and ADP. She notes that platelet aggregate together by binding opposite ends of the fibrinogen molecule using the same receptor of both molecule of the platelets. Which of the following receptors was most likely isolated? Yes. What do you think the answer is?
So it's the GP2B and 3A, because if fibrin comes when platelet to platelet binds, and what binds platelet to platelet is the GP2B and 3A.
Exactly. So we know that what happens that when adhesion occurs, ADP is released, and when ADP is released, it causes the exposure of GP2B 3A receptor on the platelets, and as a result, thromboxane A2 is synthesized by the COX, and it is released along. That's also causing platelet aggregation. So the answer over here is GP2B3A because it kind of gets activated within the presence of ADP. Okay. Does anybody have a question to this question? No? Okay. It's a very basic concept. It's written in Pathoma. If you go and read the primary hemostasis pathway, it's written in that. You can kind of go through that and ask me if you have any questions later. Okay. Okay. Yeah, I had a question. What does GP1B receptor do?
Binds von platelet to von Willebrand factor.
Exactly. So it binds von Willebrand factor using the GP1B receptor. And then what does it do? What does von Willebrand factor do? It helps in
Addition.
adhesion. Yes.
Yeah. Mhm.
So yeah, so it is, it is like the kind of the mother of platelet, hemostasis. So what it's doing is it's also, adhesing, but it is also causing platelet aggregation in the bigger picture, because if the initial factors wouldn't have been released, we wouldn't be getting the later on factors. Okay. So it's the kind of the cycle is initiated through von Willebrand. So that is why I say it's responsible for both adhesion and aggregation. That is why you also see that the bleeding time is raised within von Willebrand deficiency. Okay. Okay. So researcher is studying the effects of organ failure in mice. She finds that in mice with failure of a specific organ, megakaryocytes extend through pseudopodia and the bone marrow sinusites, which leads to a decreased shedding of proplatelets. These mice are found to be deficient in a specific hormone. Which of the following is the organ that most likely fail in these mice? What do you think is the answer, guys?
It's the
C.
liver, TPO.
Liver.
TPO is produced in the liver, so that's what's responsible, because it's the megakaryocytes that's affected.
Exactly. Liver. So what is the role of spleen? Why couldn't it be spleen? What's the function of spleen, guys? Come on, we're all doctors. We should know the function of
Destruction.
Myriad of RBC.
Destruction of RBC.
exactly. Exactly. What is the function of bone marrow?
Production
B
of blood
cells.
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 Stem cells.
B and T cells. Stem cells.
Exactly. So we know that the answer is the liver over here. And why is it the liver, guys?
TPO production.
Oh.
Exactly. So we're going to the next question. We have a patient, platelet count is decreased. Which of the following is the best initial, guys, initial treatment? What do you think the answer is?
Prednisone.
Prednisone.
Very good.
Because prednisone suppresses.
So
Suppresses.
we know that we're talking about immune thrombocytopenic purpura over here, right? Because the platelet count has significantly decreased. It's usually idiopathic. It can occur due to any, after any viral condition as well. So we have a massive drop in platelets that is referred to as idiopathic thrombocytopenic purpura. Initial treatment is prednisone. So initial treatment will always be medical treatment. Do not go for splenectomy. A lot of students yesterday went for splenectomy. Poor person got the spleen removed without even, trying for the medication option. So do not go for aggressive treatments when they're asking you for the initial treatment. Okay, initial treatment is always medication. We will try to suppress the immune system because it was an immune problem. So we will so steroids help in controlling the flares of that. So that's why prednisone is the answer. But if it still wouldn't be cured, then we would do splenectomy. Okay. What are the laboratory findings in immune thrombocytopenic purpura? What will happen to the PT and PTT? Will it be normal or raised?
Normal.
Very good. It's not a clotting factor problem. It's a platelet problem. Okay. What will happen to the platelet count?
Decrease.
Platelet count will be decreased because they are going to destruction.
Exactly.
Platelet count will be decreased.
So usually it is self-limited. We do not treat it if the platelet count is less than 30,000. Okay, so when the platelet count goes less than 30,000, then we treat it. Otherwise, we don't treat it. It's a self-limiting condition. So we don't treat it unless the platelet count goes less than 30,000. We treat it then with steroids or splenectomy. Otherwise, it would self-resolve after the viral infection has passed. Usually it's idiopathic. We know that it is a production of IgG against platelet antigens. Which platelet antigens?
GB2B 3A.
Exactly. Very good. So, it can also occur in childbearing ages. It may also occur, if a patient has autoimmune diseases because it is an immune condition that's happening. So, as we learned in the previous modules, that autoimmune conditions go together. Okay. If you have an autoimmune condition, that means you're more likely vulnerable to be having another autoimmune condition. So, you need to remember that. And yeah, so I think that's it. Okay. So if we go, what is statin? What is pravastatin over here?
To
Treatment
reduce cholesterol.
cholesterol, hypercholesterolemia.
What's prazosin?
Tazocine.
It's an alpha blocker.
Exactly. It's an alpha blocker. What is pantoprazole?
PPI.
Very good.
PPI.
PPI.
So we know the drugs as well. Activated protein C in conjunction with protein C cleaves which of the following factors, guys? Factor.
A.
Well,
Factor
factor.
5 and 8.
Five.
Exactly.
5 and 8.
So 8 is not here in the stem.
So
That's why the answer is
Exactly. So it is factor 5 Leiden deficiency. Have we read about factor 5 Leiden. So what's happening in factor 5 Leiden?
It's mutated, so it doesn't bind protein C or S,
And
and it causes genetic coagulation.
Hypercoagulability.
Yes, like more coagulable, thrombosis and this stuff.
exactly. So we know that factor 5 Leiden, it is a mutated form of factor 5 that do not has the cleavage side for, to get deactivated by protein and C. We know that. And as a result, what is happening? We are getting a hypercoagulable state. It is also what you need to remember, that it is the most important cause of a hypercoagulable state in our body. Okay. Okay. So we will go to the next question. It says that there was this boy who had history of epistaxis. You had bruising, dental procedures, okay, new onset GI bleeding. His gingiva are swollen, shows normal. Okay, so now everything is normal. What's happening? Normal platelet, normal PT. You have increased PTTT. Okay, and
the blue.
what do you think is the problem over here?
and the bleeding time is also
What
prolonged.
E.
That's why
Von Willebrand.
von Willebrand disease.
Exactly.
Vulnerable.
This was, a distractor between hemophilia A and von Willebrand. So, they were going right. But as soon as they said bleeding time, increased bleeding time, prolonged bleeding time, then that means that now our diagnosis is strange. Okay. So we see prolonged bleeding time and increased PTT because of factor 8. We see that in von Willebrand. If it would have been hemophilia A, then what were the labs? If it would have been hemophilia A, what would have happened to the bleeding
Very
time?
normal.
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 Should be normal.
Exactly. What are Bernard Solier and Glanzmann thromboasthenia? What do you mean by that?
Bernard's
Platelet factor.
genetic
The
group
Platelet
1B
aggregation
deficiency.
defect.
Yeah, and what's happening in these conditions?
with Bernard Solier is a deficiency or a defect in the GP one
1B.
B,
1B.
and the Glassman is the 2B3A.
Exactly.
Yes.
So in one we have a platelet adhesion problem, and the other we have a platelet aggregation problem.
Yeah.
Okay. And what is the treatment that we will give?
Anticoagulant.
We usually give steroids as treatment. Okay, prednisone is usually the treatment for this as well. Okay. Okay. Then we'll go to the next question. Okay. So 2 weeks later, there was this boy who presented with TB. He took isoniazid. Okay. 2 weeks later, he presents with the ED with severe fatigue and pallor. We know that he is having anemia, increased LDH, increased reticulocyte count. Stain with supravital stain is shown. Yeah, I don't see the stain over here. I think that's what she was referring. His mother recalls that the boy's father had similar symptoms many years ago and was told to avoid fava beans. Guys, they threw a very important word, fava beans. What do you think is happening over here?
G6PD deficient.
HPDD
Yes,
deficient.
experience definitely.
Very good. And what do you think is impaired?
NADPH.
NADPH.
Exactly. So, can anyone tell me a little bit about G6PD deficiency? What's happening in G6PD?
No G6PD. No NADPH. No glutathione reductase. So there will be the more oxidative injury. Yes, because there is nothing who can there is no antioxidant against the free radicals.
And there
Exactly.
is, yeah, there is damage to the red blood cell
Red
membrane
blood
because of the free radical formation, so they undergo hemolysis.
Very good. And what are the triggers of it?
Sulfur drugs and uh, also the isoniazide and then fava beans.
certain food.
Exactly. And some of the anti-malarial drugs as well, like,
Yeah.
primequine, some artemether drugs as well. Some anti-malarial drugs also trigger G6PD deficiency as well. Okay. So, yes,
And
you're right.
here in peripheral, we can see the bite cells.
Yes, we do see Heen's bodies. And
Bite
And
cells?
Yeah. Because
we
we see the
see,
Heinz body because the red blood cell breaks down very, very fast.
exactly. So we talked about what G6PD deficiency is. We know that if there is less G6PD, there will be less NADPH, and as a result, we will going to be having reduced glutathione that causes oxidative injury by hydrogen peroxide, and as a result, we have intravascular hemolysis. Okay. Know that the triggers over here are anti-malarial drugs. Sometimes isoniazid is also there. Fava beans, sulfur drugs. They all cause they trigger G6PD deficient. They trigger hemolysis in those patients who are G6PD deficient. And Hem's body is also precipitate in these conditions. It presents with hemoglobinuria. That means that you're having, blood in the urine, and you also have back pain hours after exposure to the oxidative stress. So that is also important for you to remember. Hemoglobinuria and back pain. They did not, kind of say it over here, but hemoglobinuria. We talked that LDH, increased LDH. It means that any hemolysis occurring. So this is also a nice distractor or a segue into G6PD deficiency. Okay. So what is pyridoxine? What is pyridoxine over here?
B6.
Okay. What is thiamine?
B1.
B1.
Very good. Okay. So we come to the next question. There was this 8-month-old girl who has been fed whole milk since infancy. She presents to the ED with pallor, fatigue, and decreased activity. The physician suspects iron deficiency, anemia, and orders blood lab tests. Which of the following will be most consistent with the diagnosis? What do you think the answer is?
Yes, the elevated level of RDW ratio. RDW, the RBC distribution will become increased in the iron deficiency anemia because it is microcytic. It's not the A. The retic count will be not be elevated, and the decreased total iron binding capacity. No, it's the in the iron deficiency. It's the high, and the hypocellular marrow is not here. That's seen in the aplastic anemia.
Exactly. So we know that RDW is increased in iron deficiency anemia. Where do we see RDDW that's normal or decreased? Where? What condition? Thalassemia, guys. That
Thalassemia.
is the
Yeah.
only differentiator between thalassemia and IDA. Of course, there will be other, things. For example, if we give iron to the patient and the iron corrects, then probably it's IDA and not thalassemia. but usually they don't throw this within the vignette. So they're going to paint a picture that overlaps with iron deficiency anemia and thalassemia, and the only way you will differentiate between both of them will be RDW. Okay, and if the RDW is high, then that means it's iron deficiency anemia, but if it is normal or decreased, then that means it's thalassemia. It is very high yield for you to remember this fact. They are going to ask you again and again on NBMEs as well. This is very important. If you guys have a notepad, write it down, or if you want to annotate it, annotate it or memorize it, but that's very important for you to remember. Okay, where do we, why not decrease TIVC?
In iron deficiency,
Iron
TIVC
deficiency anemia.
increased,
Yes.
not decreased. Yeah.
So now we dismiss.
Exactly. So we know about that. Okay, we now come to the next question. There was this disease characterized by, oh my god, I told crab mnemonic to you guys. Which of the primary pathological processes in this condition? What's happening? What is this condition?
Multiple
Multiple
myeloma.
myeloma.
Very good.
Neoplastic
That's
proliferation of plasma.
proliferation of plasma cells.
Yeah.
Okay. And what do you think the answer is?
B.
B?
Yeah.
B.
Yes. So this is the answer. What I want you to remember that on NBMEs, they give you picture of lytic bone lesions. So what are lytic bone lesions? Lytic bone lesions are, these are small, small circles. They will give you either within the skull or even in the, any bone of the body. And they give you pictures of lytic bone lesions. So I want you to see how they look like because they give you NBME pictures of this. This is very high yield for you to remember. I'll show you a picture of you guys of how it looks like on the, yeah. So if you see this picture, what's happening? Yeah, continue. Why is it asking me for cookies? No, I don't want to give you my cookies. Oh, what's happening? Okay, continue. So you see that what's happening over here. I'll go to multiple myeloma. Where is multiple myeloma? Did they? Oh God, where is multi? Yeah. So you see that this is the picture, and I cannot, kind of make it big, but you can see that what's happening. So these are the, you see that there is reduced density over here as well as compared to the upper portion of the bone. Okay, so this, they're going to give you this sort of picture, or like where what lysis is happening and there is lesser bone density. Why is there lesser bone density? If you see, the upper portion is a little bit wide and the lower portion is a little bit darker. Okay, so what is happening is that the calcium from the bone is getting plucked out and thrown into the bloodstream, and that is why we're having hypercalcemia. Okay, and the bone has become fragile. So they are going to give you pictures like this on the NBME. It's very important for you that you go through the picture as well. Okay, where do we see neoplastic proliferation of the myeloblast? Where is it? Where is that happening?
AML. In the
AML.
AML, it will be seen.
Acute myelocytic leukemia.
Exactly. So what I want you to remember the picture from this multiple myeloma, and as I showed you that the bone becomes lesser in density. So what can happen? Fractures. They can also give you a patient who is having multiple bone fractures. Why? Because the bone mineral density has decreased. They may give you a middle-aged patient, so you're confused between osteoporosis. If she's a woman, so that is how they confuse you. For example, if there would have been a 50-year-old woman and she's postmenopausal and you're thinking, oh, she's having fractures, she's postmenopausal, maybe it's osteoporosis, and then you see the labs that the calcium is raised, there's renal insufficiency, you see the spike. So then you think it's not osteoporosis, and they're talking about multiple myeloma. So rib fractures and the picture for you, it is very important for you to remember. Okay, how do we diagnose it? We diagnose it by serum protein electrophoresis. And if the serum protein electrophoresis is not given, then go for bone marrow biopsy. Okay, sometimes they don't give you serum protein electrophoresis. If they don't give you that, go for bone marrow biopsy. Okay, is it clear, guys?
Yes.
Yes.
And what I want you to remember that, amyloid deposition, because we talked about how amyloid gets deposit within the kidney, and that is why we're also having Benn's proteins and renal amyloidosis. Sometimes they can also give you a vignette where amyloid deposition is occurring within the heart. Okay, and it can present with as a diastolic dysfunction, so that's called cardiac amyloidosis. Because this is amyloidosis happening, it can get deposited anywhere within the body. So most likely they ask you about kidney, heart, amyloidosis. So that is, they may also give you a patient who's going through heart failure, and then you're like, oh, what's going on? And then you see that, oh, amyloid deposition is occurring. So that is why it's very important for you to remember. Okay, we'll go to the next question. A disease is characterized. Okay, I think we did this right. So, a 35-year-old man who recently immigrated from Nigeria, he presents to his primary care physician with a 6-month history of increasing intermittent fever, fatigue, and night sweat. Okay, so Africa, beef, we are seeing fever, night sweats, large Mars on the right, mandible, starry sky. I think I mentioned when I was teaching you something. What is a risk factor for this condition? Come on, guys. Fast.
It's
It's in
Condition
Barbados.
is
Burkitt's lymphoma, so
yeah.
EBV.
Exactly.
It's
What is the
EBV.
transformation in Burkitt's lymphoma?
You have the starry scar as
Age
activated
14.
factor.
It's age
814C,
14.
14.
Age
14.
14.
Humite gene,
Mhm.
814.
814. Yeah.
and the heavy chain
814.
And the virus that is common is
trans
Epstein-Barr.
T40.
Exactly. So, I think what does dietary nitrosamines do? What is this? What type of cancer does it cause? What?
Bladder.
Gastric?
Yes, gastric cancer. So
Oh.
dietary nitrosaminoles, vitamin A, it causes gastric cancer. You'll read it in the GI module. What does we know that alcohol is bad for overall. We know that smoking kills lungs. But important factor is that smoking is not the cause of death for in lung cancer. That's an important fact which I learned recently, that smoking, yes, it does causes lung cancer, but with the type of lung cancer that it causes, people usually don't die, and they die because of adenocarcinoma that's more common in non-smokers. So that's something interesting that I learned regarding smoking. So I thought that I'll share it with you guys. What is industrial exposure in dye and rubber industries? What type of cancer does it cause, guys? Come on.
Renal
Bladder.
cancer.
Bladder. So it causes bladder cancer. Okay.
Yes.
Then we're going to the next question. There is this 53-year-old man presents to the physician, complains of fatigue, anorexia, diaphoresis. Okay. He had a 922 translocation and we showed increased neutrophils. What do you think is happening over here? What do you think is the answer over here, guys?
CML.
Okay. And
Answer
what
will
is,
be increased tyrosine kinase activity.
yes.
Yep.
What is the treatment for CML?
Imatinib
Imatinib, yeah.
What does it do?
as a tyrosine kinase inhibitor.
Exactly. Yes. So we're going to the next question. Okay, there is a 64-year-old man presents with a PCP for a regular checkup and notes that he has been feeling weak and lethargic. Physical examination shows diffuse lymphadenopathy, parasplenomegaly is also happening. Okay, very interesting. Platelet count is okay. Sure. Leukocyte count is elevated. HP is okay. Leukocyte differential, they see that we have 60% lymphocyte. So which means you're talking something about lymphocytosis. We do not see the picture over here. So yes, there is an error from our side. I apologize, guys. Dr. Hamza, Dr. Ahmed will look into it. Why didn't the picture pop up? What do you think the answer is?
The patient has an increased WBC, so maybe it's prone to infection.
Okay. And what do you think the disease is going on?
I think this patient has the CML, right, which leads to
CLL.
hypogammaglobulinemia because all the leukocytes are kind of decreased. So this leads to leads the patients to have increased susceptibility to infections. I don't know if you can hear me.
Yeah, I can hear you.
Mm-hmm.
Okay, yes, you're right. So does somebody else have to give an answer to this?
Looks like CLL.
Looks like CLL.
Hepatitis.
So whenever we usually have WBCs, very, very high, then what are we talking about?
We
Leukemia.
have we have to rule out between leukemite reaction and the CML.
On
We can differentiate on the basis of if the leukocyte count is very, very high, we can differentiate between these two conditions. Is it the leukemite reaction or is it the chronic myelogenous leukemia?
I
Uh,
think CLL can be the answer because in CML, neutrophils and everything will be high, but lymphocytes are high, so it raises suspicion for CLL, right? Chronic lymphocytic
Exactly.
leukemia. And
So
yes,
it is chronic lymphocytic leukemia because in that we see lymphocytes cuckoo. Usually, the WBCs are not this much. I think I don't know why in the question they have it's not mentioned, but usually the WBCs are very, very high. You will see 70,000, 80,000 per. And the lymphocytes are like 80 to 90%. So it's usually I think it's CLL. Um, and what
and
we
also there is like lymphadenopathy and hepatosplenomegaly, which we generally see in CLL.
exactly, I think there should be a picture of smudge cells so they can kind of differentiate between that. I think also what's the next best step on of CLL? What do you think the answer is? What are we going to do if it's CLL? Then what? How do we
It
kind
will be still blast.
no, we can exclude the one by one. That's the this is not there, A is not here. So we have to differentiate between B and C. Either it's B or C. I was
Uh,
also confused in this question, but I think it was the CLL, and in the CLL, there is it's not the progression of blast crisis; it's the increased susceptibility to infection.
yes,
So
that's the answer.
Yes,
exactly.
yes.
Progression to blast crisis, what in what condition does that happen?
It
In
is
in
the
AML.
acute conditions.
acute
It
acute
should be in the ALL,
It could
AML,
not
it
be
happens
in
in
the
for
AML.
the
CLL.
infarction of the spleen or something.
Yeah, exactly, guys. So we are talking about CLL over here, chronic lymphoid leukemia, because the WBC count is very, very much raised. I think in the question they did not mention that the WBC count should be very raised erratically. Usually on the exam, you will see 50,000, 60,000. Okay, and the lymphocytes over here will also be raised dramatically. If they're going to ask you what the next best step is, then the answer is quantitative immunoglobulin assay. This is an NBME question. They will ask you this on the NBMEs. On step one, it is very high yield for you to remember. It's not mentioned in Epathoma. I think it's mentioned in the U world, but the next best step for CLL will be immunoglobulin assay. And when you do the immunoglobulin assay, you will find out that the lymphocytes are very, very high in that. Um, so that's what you are going to see. And so usually that immunoglobulin assay, you can see that there will be increase in monoclonal immunoglobulin. That's also why we're having susceptibility to infection, because if you're going to have monoclonal immunoglobulin, that means they have lost their polyclonality, and as a result they're not able to fight off infections. Okay, so immunoglobulin assay we will do. What will we find on immunoglobulin assay? We will find that what will we find? Monoclonal immunoglobulin. Okay, and that is why we're having increased susceptibility to infections. Is it clear, guys? Does anybody else want to ask a question? They can go ahead and ask me any question they feel.
Can you explain? Sorry, Can I just ask for the blast crisis? Could you just go over that a bit for me?
Yeah. So why isn't it blast crisis, guys? Where is blast crisis happening?
In acute,
In
In
acute.
acute
yeah,
lymphocytic leukemia.
Exactly. So we can also go through ALL. So what does ALL do?
RROT. We see RROT.
that's
Exactly.
amen.
Exactly. And usually they will give us a children in ALL. Okay,
Yeah.
in chronic they give us adult. In ALL we will see a child who will have oral rods, and okay, so that we will see in that patient as well. Okay, ALL is TDD positive. We also know that. Okay, and we also see that it will progress into the blast crisis. Where do we see autoinfarction of the spleen?
Sickle cell anemia.
Sickle
Sickle cell
cell.
anemia.
Exactly. Where do we see DIC?
A
Septicemia.
AML, APML.
Septicemia. So.
Exactly.
Like
What I want you to remember that Down syndrome is also associated with ALL, so they might ask you that as well. So okay, we can go to the picture. 15th question. There is this 40-year-old immigrant from Kenya. He comes to the clinic with a large growth of his mandible. I think this was asked already. I don't know why they asked again. A biopsy taken is shown in the image. What do you see, guys? What's happening?
Starry nice, starry sky.
And what will
starry
be
sky.
the chromosome?
Bucket
8
lymphomia,
14.
814.
Exactly. So we go to the 16th question. Okay, there is a 65-year-old African American woman, and she was brought to the ED in a combative state after being found wandering aimlessly in a park. After mild sedation, she says that I've got pain in my head and I cannot move my left foot. The patient is febrile, and multiple punctuate red lesions are visible on the inside of her mouth. When we see that the platelet count is 10,000, serum creatinine level is very high, shows numerous schistocytes. The patient undergoes plasma exchange, and then she is discharged. What is the most likely cause of the patient's symptoms? What do you guys think the answer is?
It's E.
It's
But I don't know how to explain that.
TTP.
So,
I guess it's
no.
Clear
TTP,
level.
but don't know how it's correlating to E.
so why is the answer E? Why do you think what's happening in this picture, guys? What's happening?
Is it TTP?
Volvina Brown multimers cannot break down.
The schistocyte. Yeah.
It's the Adam T13
Yeah.
deficiency. That one, Adams.
Yeah,
Adam ST. 13.
Adams S13.
Also, it can be AGUS, like hemolytic uremic syndrome, some kind of like
There's no
any.
renal, but there's no renal problem here.
Yes,
For
there
me,
is renal problem. Creatinine is high.
oh
There's
yeah.
renal.
What is the classic picture of hemolytic uremic syndrome? What is the classic picture of hemolytic and TTP? How do you differentiate between TTP and hemolytic uremic syndrome? How?
In
Neurological
TTP? Yeah.
involvement.
Exactly. So what's happening over here? What's happening is TTP, because you can see the pentad over here. You can see that there are schistocytes. The creatinine is very high. She's having neurological problems. She is also febrile, which means she probably has fever as well. So you see the classic pentad of thrombocytopenic TTP. Okay, and what do you see TTP in TTP? You see strokes as well. So which means if she has something neurological problem, and you see that the creatinine is high, there's low platelet count, you see that there are schistocytes, TTP is happening, and usually is because of this reason. Okay. Where do we see hemolytic uremic syndrome? What is it? What is that usually caused by?
But
Diarrhea.
Shigala,
E. coli sugar toxin.
yeah.
Exactly. Sugar toxin, diarrhea, it presents with bloody diarrhea, and then you also see kidney creatinine will be high. You will see schistocytes, and that means you're usually talking about hemolytic uremic syndrome. Another fun fact I want you to remember that HUS progresses to TTP as well. So that
Dr. Meek, why not B?
yeah, an immune attack against platelet surface antigens. What does this mean? If this was the answer, then what would have been the condition?
ITP.
ITP.
You don't see in ITP we only have decreased platelet count due to mysterious reasons. Now that mysterious reason can be viral, it can be idiopathic, it can be autoimmune. You do not see raised levels of creatinine. You do not see neurological compromise. You do not see a patient who is very febrile, and you do not see schistocytes in ITP. Okay, this is the classic picture of TTP that they're talking about, and it is occurring due to this reason. Antibodies directed against metalloproteinase. Okay.
Thank you. Thank you.
You're welcome. Okay. Then we have this next question. We have a 76.
Yeah, I'm like confused about like antibody against metalloproteinase. So are they talking about Adam TS3 or
Yeah, they're
TS13?
talking about that.
Yes,
Yes.
it's Adam TS13
Yes.
patients.
Okay, got it.
Okay. So we come to the next question. There's a 76-year-old man. He presents to the ED. He is having, okay, what do you mean by obstipation? What's the difference between constipation and obstipation?
I thought it was when I saw it, I thought it was a misspelled.
Obstipation is complete block, no flatulence as well, nothing.
Very good. And in constipation, usually you pass gases. So, and in obstipation, you do not even pass platus or gases as well. Okay, so that's complete stool blockage. Constipation is partial. He reports fatigue, changes in bowel habits over the period of year, including dark stools. On physical examination, his it's distended. Barium enema reveals an apple core lesion. What do you mean by apple core lesion?
Malignancy,
Malignancy, basically.
colon carcinoma.
And biopsy demonstrates an adenocarcinoma. We know that in usually in colon cancer patients, we have iron deficiency anemia because that's bleeding. So in any adult man who's over 60 years old who presents with iron deficiency anemia, it is colon cancer until proven otherwise. Okay, those are the guidelines. If you have a 60 and above year old patient, he's presenting to your clinic with iron deficiency anemia, it is usually colon cancer until it is proven otherwise. Until you prove it that it's not, colon cancer. Okay, this is very important for you to remember. Whenever you see colon cancer and that patient is having bleeding, low lab counts, then probably they're hinting you towards cancer. For example, if this question would have been flipped, they would have given you the labs. They would have given you a patient who's having weight loss, who's having issues with his sleep, with bowel movements. What would you have done?
So will be
Exactly.
colon cancer will be in the differential. Here, it will be
Right-sided
because
colon
of
cancer or left-sided colon cancer?
usually the
Right-sided.
right-sided colon cancer. It will be the right-sided colon cancer
Very good. So it will be the
because
right.
because the left-sided colon cancers basically they usually present with the obstructive kind of symptoms, and the right-sided cancers usually present with the anemia,
Yeah.
blood loss.
And left-sided also presents with hematochezia. That's also very important. But, we'll cover that in the GI module, so don't worry if that's, but, I wanted to say that 60-year-old and above, if it is iron deficiency, then it's colon cancer until proven otherwise, okay? So we know that what type of anemia they're talking about. They're talking about iron deficiency. Usually MCV is given, guys, so do not worry. It's not mentioned over here, but in the exam, they always give you the MCV. And MCV would be probably less than 80 because it's microcytic anemia, iron deficiency anemia. Okay.
I have a question, doctor.
Yeah.
on obstipation. Can you qualify feculum as obstipation?
Subcolon is also obstipation. No,
No, the word obstipation there.
no, obstipation is a condition like constipation.
Okay, but when you, because I was reading a book, I saw a feculum, like the hard stool in the intestines. Is that what, can we qualify that as obstipation?
No. So obstipation is a condition. For example, it's like constipation. So whenever a patient is constipated, we say that they are not able to pass flatus or sorry, they're not able to pass stools, but they're able to pass flatus. Flatus means gases. Okay, but in obstipation there is the complete blockage, no flatus and no stool. So that is obstipation. It's like the complete obstruction of the stools.
Okay.
Okay, got it. So,
Excuse me, Dr. Maheen.
yes,
Here in these questions, can basically the pathology was the colon cancer that caused the microcytic anemia. It's clear to me, but is it because of anemia of chronic disease or because of iron deficiency? Because both of these conditions causing the microcytic anemia.
iron
But I
deficiency.
Iron
think,
deficiency.
but in the how we can exclude the anemia of chronic diseases, not the.
They will give you MCV over here as well, and which they did not give, but they will give you MCV. And anemia of chronic diseases usually happen in, in like autoimmune conditions. For example, if you're having rheumatoid arthritis, SLE, long standing autoimmune conditions, then only you have anemia of chronic disease. Usually it's non-existent on your exams, they won't ask you anemia of chronic disease, but it's usually occurring in the presence of autoimmune disease. For example, in SLE, when you see pancytopenia, why is the RBC down? It's down because you have anemia of chronic disease. Okay, usually
Yes.
when you're having autoimmune diseases and you're having it for a very long time, that is why, and such as rheumatoid arthritis and RA, you also see that. Okay, but over here, why is because intestines also, they cannot absorb the iron and the nutrients as well, right? And why? Because they're cancerous, and as a result we're having internal bleeding because of that, and that is why we're having iron deficiency anemia, and there is also bleeding that's occurring within cancer, and that is why there are dark stools. Why do you think there are dark stools?
Yeah.
Okay.
Please, what's the vignette, if you don't mind speaking a little bit for the sideroblastic, please?
Yeah. So why isn't it sideroblastic, guys? What is raised in sideroblastic?
Lead poisoning.
Yeah, and MCHC will also be will be increased, and what else?
There is no
Um,
history of any
Ring
lead poisoning. Ring sideroblasts are not seen here.
No,
So
this
that's
is asking us generally, about she wanted us to have the concept of sideroblastic. So in sideroblastic anemia, what do we see? We see that there is defective protoporphyrin synthesis that is happening. Why is the protoporphyrin synthesis getting decreased? Why, guys? Where do we see that? It can occur in alcoholics. It can occur in lead
Yeah.
poisoning. It can also occur if there is vitamin B6 deficiency, because it acts as a cofactor for the rate limiting step.
Yeah.
Okay, so it occurs in that as well. For example, if you give isoniazid treatment again and again to the patient who's having TB, and you do not give them vitamin B6 as like a co-treatment with isoniazid, then vitamin B6 deficiency occurs, and as a result, you may have sideroblastic anemia as well. And what else?
Dehydration. Not the, hold on.
Exactly. So the laboratory findings will include that the ferritin will be high in this, serum iron will be high, TIBC will decrease, and in sideroblastic, what else is going to be increased? How do you find it? That it's sideroblastic. What will happen to the MCHC, guys?
Increase.
Low.
No, it's different.
I think it should be low.
Who said low and who said high?
It's low.
We say low.
Below
I
elevated.
think because there is impaired heme synthesis, so that will lead to low hemoglobin concentration. That I was thinking.
Okay. Does anybody else have the
Is it the
But
ion?
it is because of
I think the ion will be elevated because it's broken down, then the ion is released. So the ion will be elevated.
okay? Yeah. So we have discussed about this. Whose mic is open? Can you please just like a little bit close it down? Okay. So we have another question. We have a question that this is a 23-year-old woman and she presents with redness, bruising of her right knee, and she's also having heavy periods, there's permanent erythema, bleeding time. What's happening to the bleeding time? Is it increased? Is it increased, guys?
It's
Bleeding time
normal.
normal,
Okay. What's happening to the PTT?
increased.
Increased.
Normal.
Normal.
Oh, normal.
No, activated is normal.
Because it's 25 to 30.
What's happening to the PT? What do you think
Elevated.
Increase.
Normal.
Increase.
okay, what do you think the answer is over here?
Factor 7 deficiency.
Oh, factor 7. Not
Okay.
8.
Why do you think it's factor 7?
Because PTT is
PT is
normal.
increased.
PT is raised. So like the factor 7 is apart from factor 7 rest things are common in both PTT and like intrinsic pathway and extrinsic pathway. So only factor 7 deficiency will cause isolated PT increase and there will be normal PTT.
Exactly. So we know that
Yes.
PT is, it manufactures extrinsic clotting factors. Factor 7 is a part of the extrinsic chain. So if we are going to have a prolonged PT, then that means something from the extrinsic factor is getting affected, and that in this case scenario is factor 7. Okay. So we have another question. So there's this African American boy. He's brought due to history of severe swelling and tenderness of the feet, of the hand, of the feet. Okay, they're talking about what? What do you mean by tenderness and swelling of the hands and feet? What is this condition called?
Dactylitis.
Dactylitis because of sickle cell disease is the African American boy and having the pain swelling. So there is in the question stem they're saying the history is no significant for an is significant for an older brother who died of pneumococcal sepsis at the age 6 means that because of the sickle cell disease, the patients are more prone to encapsulated organisms infections. So the physical examination shows bilateral swelling hands means dactylitis is there. So it is the sickle cell disease is the extravascular and the intravascular hemolysis both goes on. And in the hemolysis, what happens? The serum haptoglobin level varies. It becomes haptoglobin level become decreased in case of hemolysis. So that's the abnormal. That will be abnormal. Not the complement system, not the serum albumin, or the systolic functioning of the heart and the systemic venous pressures will not be affected. Option will be the D.
Okay, yes. So we know that she beautifully explained us the concept. We know that they're talking about sickle cell. Why? Because they mentioned dactylitis. They also mentioned about pneumococcal sepsis. Remember, I told you how sickle cell patients, because autosplenectomy is occurring in usually sickle cell patients. What is happening? They become prone to encapsulated organisms such as pneumonia and meningitis and H influenza, and that is why we usually give vaccinations to those patients as well. And so we know that they're talking about sickle cell, and we know hemolysis is occurring that can mess up with the haptoglobin. Okay. So we can
Dr.
come.
Maheen, I had a question. So
Yeah.
the serum haptoglobin, is it more related to your extra or intravascular hemolysis?
Sorry, can you?
Intravascular.
It's intravascular.
So I just had a question on this. I keep on getting confused. In Pathoma, I think hereditary spherocytosis and sickle cell anemia, these are given under the heading of extravascular hemolysis. So over here, we're having an intravascular hemolysis, or do we have both in sickle cell
We have
disease?
both. We have both in
Both.
sickle cell.
Yes, both in
They
sickle
are
cell
both.
disease.
We
Yeah.
have
Okay,
both.
okay,
We have both
okay,
But
thank you.
in
and extra.
hereditary spherocytosis, only the extravascular. In the sickle cell,
Exactly.
Okay.
both extra and intra.
Yes.
Okay, so we have the 20th question, and okay, a 23-year-old man, he's coming to the clinic for a follow-up appointment. Laboratory results, okay, hemoglobin. The patient has otherwise been normal. He feels that his energy level is normal, and he has run several half marathons. We see the picture over here. What are these cells, guys?
Target cells.
We have
Target.
target cells there.
And where do we see these
We have
target
red
cells?
blood cells.
Where do we see what's happening over here? What do you think the answer is?
Beta thalassemia.
Erroneous mRNA splicing
Okay, yeah.
Yes, splicing.
Talk
So
about the
processing.
point mutation. I think this is a repeat question. We solved this one type of question in UWorld as well. So we know that it's a point mutation that's occurring. We're talking about thalassemia over here. That is why we're seeing target cells. We also talked about how the patient feels fatigued as well. We know that the MCV is what is happening with the MCV, guys? It's low.
Low.
very
It
low.
is
We know
low.
that MCV low is in conditions of, iron deficiency anemia. It's anemia of chronic disease, thalassemia, and what else?
And lead poisoning.
Sideroblastic anemia, yes.
Yeah.
So that is why we are having target cells. That is why the patient is feeling fatigued. We're having anemia. We know it's due to a point mutation, and it's because of this. So, why isn't it elevated oxidative stress? What would trigger that?
G6
Sickle cell
PD
disease.
deficiency.
These are
Destruction
not
of
the Heinz
RBC.
bodies. In the picture, Heinz bodies are not there. In the G6PD, we see the Heinz bodies and the bite cells, but these are the target cells.
Yes. Where do we see impaired heme synthesis?
Because of lead poisoning or the sideroblastic anemia. And the
Okay.
complete gene deletion will be seen in alpha thalassemia, and the cell membrane instability will be in the hereditary spherocytosis.
Okay. Yes. So what are we going to have is, okay, what is in cell membrane instability? What's happening in that?
Yeah, there is the integrity defect, spectrin and chirin, and the spectrin and the chirin defect, and the membrane becomes unstable, and it becomes spherical in size. That's why we say it as the hereditary spherocytosis.
Yeah. So we know that membrane becomes unstable in hereditary spherocytosis, and that is why we're having hemolysis in that as well, because the membrane it's not right because of the cytoskeleton problem. So I think we are having 20 questions are done for today. We have run out of time. As much as I want to continue the session, we've run out of time. It was a 1 hour session. And I think the rest of the questions you guys can, if you are finding any difficulty in that question, you can come up to me, you can ask that in the group. We'll try to answer them and kind of take it up in the next session. To If you have any questions, put it up in the next session. I'll try to answer them. And I think that's it for today. Do you have any questions, guys?
Doc, can you have this remaining 20 questions after Dr. Ahmed's class? Because these are really important and nice actually discussing this question. Clearly, lot of confusions actually.
Okay. Yeah, sure. So you can, I'll discuss this with Dr. Hamza, and if we are going to continue these 20 questions after Dr. Emma's class, then he'll probably share it in the group. Okay.
Sure, Doc, sure. That would be
Oh,
nice.
he'll
Yeah,
share it
thank
in the
you.
group. If we are going to have a 20 other question class, then he'll share it in the group. He'll share you the link as well. You guys can join it after Dr. Ahmed's class. And I think now we're having Dr. Ahmed's class, so good luck with that. And yeah, I'll see you guys. Okay.
Thank you so much. Thank you so much, Dr. Maheen, for being here and having such an amazing session. So yes, Dr. Amis, we'll definitely just discuss it with our team, Dr. Hamza, Dr. Laiba, and yes, we might have like the remaining discussion after the session. We'll just consider that. Okay.
Yes, thanks, Doctor.
Oh, thank you so much. Okay, so let's have 10 minutes of break and okay, 5 minutes of break, not 10, right? Then we'll be starting our session, right? MSK. Thank you so much.
Dr.
Okay, guys.
Ahmed,
I'll see you
quick
after.
question.
Yeah, Dr. Jocelyn. Yes.
I was wondering if you can have the PDF document just so we can revise later if we're unable to complete after.
Yeah, sure. I'll share it on the group.
All right, thank you.
Okay. So I think after Dr. Ahmed's session, I'll see you guys. Okay. Until then, happy learning. Bye bye.
Take care, Doc. Bye bye.